Greetings, everyone. This is Eric Laser, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations across our land. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this strategy of finding a bright spot and cloning it is the most effective way of changing healthcare for the good during our lifetime. Our topic today is super important. It is around Medicare Advantage and the next generation of home health strategies. It is more than just home health here, folks. It is more than just providing care and caregiving. This is about creating a more equitable access to quality healthcare for the most vulnerable in our population. It's about improving your business through reducing total cost of care, through improving your CAHPS and star ratings. And to deliver all these great ideas for you, we have this all-star panel in front of you today. They are Randy Klein, the Chief Executive Officer at Vesta Health; Dominique Morgan, a last-minute addition. She's the Chief Operating Officer of an exceptional non-for-profit called Leads. David Wethington at Elevance Health had a last-minute urgent emergency meeting. He had to drop out. He apologizes. And Dominique, an old friend of the show, was kind enough to join us with just about 16 hours notice. We also have Chase Dailey. He's a principal of home solutions at a little-known organization called Humana. And we have Dr. Susan Beane. She is the Executive Medical Director of Clinical Partnerships at Healthfirst in New York City. Now, as usual, we're going to save some time by bypassing the reading of full bios. We're going to post a link to them in the chat for the live attendees, and we are also going to put a link into the show notes in the description of the podcast if you're listening to us on your favorite podcast app or on YouTube. Today, our partner in crime and sponsor is indeed Vesta Healthcare. If you haven't heard of Vesta Healthcare, you should check them out, vestahealthcare.com. They improve caregiving and care at the home by combining a personalized care and support approach with easy-to-use tools and technology. They connect the entire care team, patients, family, caregiver, insurance plan, agency, doctors, nurses, to support the best possible holistic longitudinal care at the home. And you could, again, learn more about them at vestahealthcare.com. I'm going to tell you more about them later on in the show. We have a lot to cover. Q&A module, folks, at the bottom of your screen. We're actually going to ask you for feedback and topics we should cover in 2024 and how we did today so we can get better through our feedback form. That's going to be an email coming from me in about 45 minutes. I'll continue emailing you again if you don't answer, so please give us your feedback. It's only about 2 minutes to complete. Let's get started here. I'm going to start with Chase Dailey at Humana. Chase, as CAHPS and the Health Equity Index evolve, I know our strategy overall for delivering care is changing. The home is becoming more and more critical in achieving a lot of those clinical and customer satisfaction ratings that drive the business successes, all the things I alluded to in my intro. How is Humana reframing their overall strategy around the home now that they're a Medicare-only plan, and what is unique in some of the key components to delivering on that strategy, Jay?
Yeah, it's a great question, Eric. I think for Humana, we've always understood the value of care in the home. And if we think about it from the historic insurance payer side of things, we've always had a lot of effort going into building out our networks that allow us to have a lot of providers available to our members that can provide care in the home. Because it really starts with that access. If you don't have providers in the network that can provide that level of care to your patients and members, then you never get the value out of it. So we've really been in the game of having adequate and exceptional home health providers available to our patients for many, many years. Now, what we've seen at Humana in recent years is really an evolution of that, which has been kind of centered around our expansion from that insurance and payer partner to a provider as well. So folks may be aware, and hopefully with growing awareness of our CenterWell Care Delivery Organization, which evolves us from not only being a payer of these exceptional services in the home, but also a provider as well. So within our CenterWell entity, we have Home Solutions, which is the business unit that I represent, which is our home health agencies that we own and operate. In addition to that, we have our primary care organization. So Humana is one of the largest providers of primary care in the nation as well. And the third pillar of that CenterWell business is going to be our pharmacy as well, one of the largest PBMs in the country as well. And a big part of that is supported through our mail delivery component of pharmacy. So for us at Humana, we think across all three of those assets, key to each of them is delivery in the home. Even our primary care business has seen a strong evolution recently of that through our primary care anywhere program. So that's something that we offer in select markets such as Georgia and Louisiana, where our MA patients have the opportunity to see their primary care physician in the comfort of their own home. So for us, home has always been key. It's an evolution of that. And I think what we're really excited about at Humana is now that we have both sides of that working together and we can bring these assets together, it allows us to provide a more integrated experience that allows us to capture the value of all of those assets in supporting our Medicare Advantage patients in the home. So for us, I think specific to the conversation today for home health, right? Our CenterWell Home Health operates 350 home health agencies across 38 states. So for us, when I think about our members and our patients that are coming on service with CenterWell Home Health, now that we have that amazing access, not only through our network of providers, but also those own capabilities that I mentioned, is we have an amazing opportunity to enhance the experience for our patients that use those assets. So our teams are spending a lot of time every day trying to better understand what the needs are for the patients that are using those capabilities and then building upon those. So we're learning a little bit more about home health specifically, right? A very complicated, stressful time, especially for a Medicare patient coming out of perhaps an inpatient setting where there's a lot of care needs for that. And there's a lot of things that we can do with what we think of as traditional home health, but there's a lot more that we can do and invest in as well. So for us, that's about evolving and building on what we call our outcomes focused model, which is really just better understanding those patient needs in those situations and providing them the tools, resources, and clinical support they need to help them get the best outcomes while they're on service with us.
That's a lot of really good information. You kind of held out on me in our pre-production call on primary care anywhere. So I need to ask you a follow-up on that. So let me just outline what I heard you say about your strategy. So the first is sort of the start of care is at home, and having sort of an integrated provider payer process is of course an advantage, and maybe not exclusive to Humana, certainly an opportunity for other organizations to create close integrated bonds with their partners to be able to deliver on this. And so that's number one. Two, and so that start of care is so important, and I'll probably ask you some questions about that later on. Assist the boots on the ground folks, whether that be a provider or practitioner, assisting them virtually is super important. Navigating, being able to have a clear content, I would say, resources so you can navigate your members to the right places outside of the home to get the care and the wellness services they need, and then having this outcomes focused model for impact. Did I catch everything? Or medical reconciliation? Did you mention that?
Yeah, that's a key part of our outcomes focused model, Eric. So you're spot on, right? So you think about the patients that are coming on service for home health after perhaps an elective surgery or an exacerbation that they had of a chronic condition, right? They're coming back to the home. It's a reintegration back to the home. It's a meaningful experience for not only them, but their caregivers or others that may be in the family. So yeah, that timely start of care, making sure that we can get out there quickly with the right clinicians to help that transition and cover all of those components of getting comfortable at home. And as you mentioned, our med reconciliation work is a key part of that delivery as well. There's a lot of changes that happen to medications during an inpatient stay, and us having the right teams engaged on the back end to support those patients is something that's really impactful for us.
Great start. So Chase, I'm going to at some point try to circle back to ask you about start of care. I
Sure.
may have a bit more about med reconciliation, and then I know we didn't talk about it, but I'd love to get maybe come back to you if we have time on primary care anywhere. So stretch out.
Happy to.
Let's bring in Dr. Susan Beane. She's Executive Medical Director and Clinical Partnerships at Healthfirst. So Dr. Beane, for those who aren't, familiar with the New York City marketplace, maybe tell us very quickly a little bit about Healthfirst and the population you serve, and then maybe enlighten us to your overall strategy to provide equitable access and home care to your members. You are on mute. Usually that's me, so don't feel bad.
Here I am.
There you go.
So thank you for having me today. So Healthfirst is, as you're saying, hyper-local to the downstate New York model area. We are serving about 1.8 million people in all of the counties of New York City, Long Island, and also part of the Hudson Valley. This includes about 215,000 Medicare Advantage members. And I would say that, we have a number of members that obviously are receiving home care for various reasons, but about half of our members receiving home care are actually dually eligible. We are serving people who are in many of our underserved areas downstate. And it is always important for us to find innovative ways to serve them. So in order to do that, we are a provider-sponsored health plan. We're actually sponsored by the majority of the voluntary hospitals downstate and a not-for-profit. And so our value proposition means that we listen to our providers and use their advice in terms of how we develop programming to improve outcomes. And around 2016, 2017, pre-pandemic, our providers brought to our attention that they had concerns about frail members, mostly in the Medicare population. And they were concerned that not only are some of their assigned members homebound, but also some they feel were on the road to being homebound. And so they investigated this and did a little bit of qualitative research, and we found together that maybe up to a third of our members in that age range and who are in Medicare Advantage reported that they were challenged with at least one activity of daily living. So this really inspired us to think together about how we might help with these members. And the finding was, after a lot of alternatives were considered, that providers in their offices don't really have the means or the capability, or especially the time, to actually connect their members to the kinds of social services that they may need to optimize their care, especially if they're frail. And, obviously I have the guru of social needs on the call with us from Health Leads, Dominique. But from our perspective, this is how we conceived of a program that we call Helping You. And Helping You is designed to provide access to resources to address needs for members identified by our providers as potentially not achieving best health outcomes because of social economic needs and other kinds of barriers. So this is not a traditional plan-based program because, as you know, most of us are addressing needs of our most complex members through case managers and social workers. We do that at Healthfirst. This model is really built on a digital infrastructure that connects primary care providers and others with community-based organizations to coordinate and navigate those members. What's interesting about this is we have found that this sort of normalizes our homebound members so that they are able to access some of the services in the community that they're not normally able to access.
I'm going to have more questions for you on Helping You. I love that. Thanks for sharing. I'll come back to you in a little bit, Susan. I want to bring in, an additional, we're talking hopefully about new approaches or old approaches done differently. And so I want to talk about sort of that whole bringing care to home into someone's life through maybe some storytelling here. So Randy, I'm going to bring you in. Randy Klein is the CEO of Vesta Healthcare. Randy, let's talk about someone living with cardiometabolic disease and other comorbidities. Can you tell us a little bit about key components that you need to have in place to ensure the home model just doesn't address the acute needs that occur from someone who is chronically ill, but sets up that individual for longer term success?
Yeah. So At Vesta, we spend most of our time focused on people that have long-term home-based care needs, and we spend a lot of time working with people that have home care aides, family caregivers, personal care aides that are considered consumer-directed, meaning that they're paid for typically by Medicaid, but don't necessarily have an agency affiliation. So, a good way to think about this is from the perspective of a patient who is supported by one of these individuals, these caregivers, both paid and unpaid caregivers, which play a very important role in the delivery system, but are largely unseen. So, early on in our journey, we had a patient named Maria. That's a fictitious name, but a real patient. And there was a lot of learnings that happened around this case. So Maria was 79 years old. She lived on the North Shore of Massachusetts, area called Lynn. She had a consumer-directed aide, a personal care assistant that came in and helped her a number of times a week. Typically, this would have been a family member. In this case, it was somebody that she had found through a local agency up there that was helping her out. She lived in a subsidized apartment building, lived alone, and my guess is most of us know a lot of people like Maria. Maria had a number of different conditions. One of them was diabetes. And one of the things that she had when she had been referred to us was a history of actually having exacerbations and diabetic events and things that were going on. As part of what we do, we work with the aides and the caregivers that are in the home to help them better understand the conditions and be able to provide us with information about what's happening in the home at a given point in time. In this case, recording glucose readings. Very, very early on, shortly after undertaking her under care, we noticed that a read of 300 had come in. That is not a good read for anybody who's wondering. That triggered as a warning and alert inside our system. And the way that we work is that the aides and caregivers in our system are supported by a team that actually follows the patient and supports them in real time. And we were able to immediately act on that. And two things happened. One, she had medications that we were able to direct her. We're a medical group, so we can direct medication adjustments and administration. So we're able to direct her aide to assist her with taking medication to reduce her glucose, and we got it down to 145. The other thing was we were able to understand from her aide what was going on. And this is a very human thing, and we've seen this again and again and again. In this case, her aide was being very well-meaning and was using one of Maria's favorite foods, a donut, to motivate her to take medication. So the aide was trying to do the right thing. Maria was accepting that assistance, and because of both lack of education and not great access, she was at great health risk. And we were able to take the access that the aide had, the position of trust that she had, and help stabilize that situation with a very simple intervention. And Maria went about her day, and we had fewer, not none, but fewer events like that, because the aide and Maria both understood, don't use the donut as an incentive.
Like, yeah, pouring water on a grease fire.
I mean, so that's the one that we talked about. I'll give you another one, which is almost identical to that actually just happened earlier this week. It was pad thai. So, they didn't think that pad thai was going to spike glucose. And it was one of the favorite takeout things. And it's like, that's all salt and sugar. And same thing. You had in this case, it was a daughter helping her parent and did not realize the impact of, serving her at that point in time. We picked it up, glucose is way up. And now she understands pad thai is not a good food to give her mom.
So could you just break down very quickly, like how all this works? Like, so you contact the aide first, and like, how do you get the aide to engage? Just take us through very quickly, like how that process works, so people get a sense of how they can build it.
So we're an independent provider group from the standpoint of the delivery system. We're primary care adjacent, meaning we don't take over for primary care, but we do, as Dr. Beane was noting, primary care is not really set up well to work with home care aides and caregivers at the pace and speed that we are, because they have to see lots of people. They have broad panels. It's not that they don't want to, it's just difficult for them to do. We're typically introduced by a home care agency, sometimes by a health plan, occasionally by primary care as well, as a resource to support the person's aides and caregivers. So we come in through the patient first, get the patient's permission to work with them, and then are introduced to the aide as someone that's helping connect the patient to care. It's a very, very lightweight process. So an aide comes in, and if they're from one of the agencies that we work with, we might actually have the ability to work through the agency's EHR, these things called EBVs. If it's someone that does not have the type of support like Maria's aide, we have a mobile app that they can download, which is connected to them, and it's also connected to Maria. And if they have biometric needs, like in this case, they have the need for glucose monitoring, we have the ability to provide equipment for that. We also have falls detection, medical alerts. So there's a bunch of stuff that all wraps around the patient and the caregiver. The way our system works is that our system knows who the person is that's reporting the information. It's actually specific to that individual, as well as who that patient is and what the escalation pathway is for that patient. So, in the example of Maria here, when we saw that read, we knew that it was her PCA that was the one that was plugging this in. And in this case, it was a manually collected read. She did not have an automated reader. And we knew that it was Maria that it was about. And the reason for that is it comes in instantaneously. So we field this stuff, typically in under 2 minutes. That's for responsive. There's also proactive available, but it's back to, sort of the human speed of care. Maria has a PCP. We are not that PCP. When, she needs to see that PCP, if in an event like this, it's literally not possible. She couldn't get there. So the alternative becomes, go to 911. Or in our case, being able to have someone that knows her complicated case, knows the, situation, can get to that information and feels confident making recommendations about things that stabilize. And then we schedule Maria for follow-up. So it's a unique space that we fill there, which is challenging for other parts of the system to fill. And it accesses, folks that are already in the home. Again, I've got a pretty strong bias on this. You've got millions of people that are in the home working with some of the most frail individuals that are out there who are a heavily underutilized workforce. And that's what we're tapping into.
Yeah, I'm going to summarize that real quick, and then I want to move on to the question, but this is important. So you contact the aide if they are not affiliated with a home health care agency. You provide a downloadable mobile app.
Yep.
You deploy as needed simple biometric equipment.
Yep.
Or blood pressure cuff, and then you focus on information sharing. So you mentioned what did you call it? This healthcare happens at human speed of care is the term you use.
Yeah. I just made that up, but it's, the human speed of care right there, where you've got somebody having something happening in real time. It can't wait days to be handled. It has to be handled right then.
Provide the information and sort of the pathways that the aide could follow to make sure that they're getting the right care. I like it. That's
yep. And even more than information, it's guidance and actually intervention, right? So if our clinician was not a licensed individual in this scenario who could instruct taking that extra medication. So if you call, a helpline, they can guide you, but they can't do a medication adjustment. They can't tell you to take a dose, skip a dose. They can't actually write an order. It's really important that we have that power of the pen in that moment to be able to do the things that allow for that stability to occur.
I want to stay sort of with the caregiver topic for a moment. Dominique Morgan is the Chief Operating Officer of a really cool non-for-profit called Health Leads. So Dominique, how, thinking about Maria's aid and providing donuts for incentives, like how are you guys thinking about comprehensive home care and caregiver programs, and how are you effectively using caregiver programs and caregiver education to close the health equity gaps in this country, and maybe provide an example of what you're doing to do that? I think that could inform a lot of our plans and providers.
Thank you for the question, and I'm delighted to be here in 16 hours of advance notice. Thanks, Eric. So just to give a little bit of background on Health Leads, we're a national nonprofit who's been in existence now about 15 years. And our mission really is to work at the intersection of both community, health system, public health, to really address systemic issues that are leading to inequities and disease in communities and populations. We have a strong belief that everyone has the right to health and also has the right to well-being and dignity when they're receiving that health. And so one of our key actually strategic pillars is caregiver. And we define caregivers both in the unpaid and the paid space. And so we look at both family members to those people who are doing direct care, such as Randy has described, so home health workers and folks like that, our CHWs and primatoras, who are also part of that caregiver and ecosystem, and doulas as sort of the key kind of key populations of folks who fall into caregiver. One of what you asked was is how are we addressing, or how are we beginning to elevate some of the issues that are cross-cutting actually across that group of folk. And we're really big on coalition building and really big on ensuring that key stakeholders have a voice at the table. And so one of the things that one of our biggest initiatives is bringing caregivers in all walks of life, both paid and unpaid, together. We meet with them actually bi-monthly, and they pick a topic, an area of focus. This year, the area of focus is financial sustainability. And we bring in folks from consulting, from policy, from public health, from care delivery, both to educate, but also to help address kind of questions and almost like learning questions that this group that is bringing together. All that is aimed towards a caregiver summit. The last one we did was in 2021. Our next one will be in May of 2024, which is the 2-day summit where they're reporting out on the things that they've discovered. They're reporting out on the next steps of how they as a coalition want to drive things forward. We're bringing in other stakeholders like folks like yourselves and payer organizations and policy folk to really address or to help support caregivers and caregiver issues in the community. Part of the reason why we think this is so important and why it is a critical aspect of kind of the concept of health equity is a couple of things. One is it's about $470 billion of worth of care that is unpaid, both by people who are either paid or underpaid in the caregiving space. So if we think about what that would look like in terms of like the economic contribution of caregivers, it's huge, right? And that's just one study. I'm sure there's multiple other ones. The other thing I think is important to recognize is that the populations that they're serving both often are on the fringes, whether they're the dual eligible folks that Susan alluded to, or our Medicare populations that I'm sure Randy and a bunch of his teams are also servicing, but also folks like young pregnant moms, especially in underserved communities, right? And ensuring, and what we know is that the data tells us that better outcomes come when we have community health workers, when we have family members who are educated, when we have doulas engaged and involved in care. One interesting fact is that about 40% of folks who are either paid or unpaid, who are providing caregiving services, whether it's in the long-term care setting to kids or to long-term care setting to family members like older adults, or in the doula space, they themselves are actually at or below the federal poverty limit. And so there's an aspect of this that is also about, if you think about what they're doing and the economic contribution as well as the health outcomes, it's great. But the sustainability of them as a part of the healthcare ecosystem we need to elevate that and think through kind of how do we ensure their sustainability. I think it's a critical component to ensuring equitable care. Go ahead, Eric.
I was going to say, I'm a big believer that we have not militarized each other as peers and consumers / patients of healthcare to providing better care. And even though aides are trained professionals, whether CHWs, doulas, family members, home aides, but they're the next step up, and we need to leverage them and provide sustainability, as you just said. So 40% of them being under the poverty line is just a staggering number. Let me do this. I see some questions from the audience, and I know I'm falling a little bit behind time here. I want to do a quick reminder of what Vesta does for all of you, potentially for all of you, and then I'm going to move on. I want to talk some follow-up questions to both Susan and to our friends at Humana, because I want to get into some of that, start of care stuff, Chase. So I'm going to flow right back to you guys. But to dovetail off what Randy and Dominique just said, if you're truly working towards equitable access to quality care for all genders, races, sexualities, disabilities, etc., or if you're just simply trying to keep your members out of expensive acute care and it's just a business driver, fine. I just believe you need to go into that conference room and erase the whiteboard and rewrite your value-based care strategy, making caregiving a core component of it. And I know most of you in the audience, you don't have caregiving as a core component to your strategy. Vesta Healthcare, in my humble opinion, they're just worth talking to because they know so much about the ecosystem here. They're a provider that improves outcomes and reduces the costs in your Medicare and dual populations by empowering caregivers and enabling world-class care at home. That keeps people out of the ER, out of the hospital, improves your star and CAHPS ratings. The Vesta model of care is a process and approach that's purpose-built for frail seniors who are either dual or Medicare eligible, and allows them to connect with paid and unpaid caregivers with a Medicare-funded clinical care team to support. And they are working with all tiers of health plan partners, collaboratively managing clinical and financial risk for your populations. How do they do this? They have a three-pronged kind of Vesta model. One's around connecting and engaging caregivers, and they do this, just as Randy mentioned, with actionable steps and a process to make caring for clients and loved ones much easier and less stressful. And they provide digital tools to support this, to engage both the members and the caregivers. They also have something called 360 Patient Insights, which is an integrated platform that connects real-time in-home observations with remote patient monitoring devices. And they also have something called 24/7 clinical support, which is Vesta's affiliated medical groups of remote clinicians, NPs, RNs, and MDs, monitoring patients, and that's available 24/7 for the caregiver or member outreach. So they combine these three things, and you could create a really effective program that provides much better health equity amongst your programs, gets folks their care where they want it at home, and improves your business model. They have an interesting content piece that they shared with me to prepare for this episode. It's called Transforming Home Care, and it's a caregiver strategy. It sort of puts into writing some of the things I just tried to outline for you. Their approach provides the Maria case study in more detail than even Randy provided just now. So if you want a piece, if you want to review that, just so you have it for information, please request it through this poll I'm going to put up, and I'll send it to you directly so you don't have to search online and go through a registration gate to get it. All right, Susan, I'm going to come back to Healthfirst and your healthy use strategy right now. How are you rethinking AIDS as a resource to ensure this high quality of care in New York City? You are on mute again. It's okay. You get 3 strikes. This is just.
I know. I will never go on mute again. So we were finding that in addition to feedback from our providers, there were many innovative home health agencies, and Randy, obviously your organization is one of them that was coming forward to sort of innovate with us about how we might better serve our members. And I think I really like what Randy said about efficiency, meaning that some of the programs were not realistic for us because we didn't want to put more layers of care in between the person and what they needed. But with helping you creating strategies that allowed us to be out in the community through the hands and feet of our community-based organizations. They are contracted to improve health outcomes. They were providing education, self-management, etc. We realized that, you know, our strategy was incomplete if we didn't provide equal and equitable access to people who unfortunately are homebound, you know, so that they could have their social, economic, and, you know, diverse, even caregiving needs met. So our home health organizations were willing to brainstorm with us. And this is how we had the aha moment, which was that, you know, if we have community health workers serving people in the community, what if we had community health worker like aides serving our members at home? And that's basically the genesis of it. It was an equity play. As in addition, it was really around health outcomes. Because as I don't want to repeat what Randy already said, but obviously community health workers are a great bridge between clinical services and the community services that people need. Our aides became a bridge between the community, the clinical linkages, and the home. And so, you know, we were able to sort of put together training through actually our training agency is on this line now. I want to call them out a little bit, Inquisit Health. And we were able to, through the digital infrastructure that we had at Healthfirst, make all of this, so these social services right, you know, put them right into the home, if you will.
Love that. Love that. Chase, let's circle back to Humana now. When you outlined the core components, or when I did it, the start of care was one that I was particularly interested in. Can you explain the importance of this part of the strategy and how it works?
Yeah, absolutely right. So again, as an organization focused on our seniors, a lot of those seniors are going to have a health episode at some point during the year, whether it's a planned elective procedure or it's an acute exacerbation they have of an existing condition. So for us, when we think about those seniors coming out, and to your comments, Eric, that start of care is just critically important for us, because when you're going through that medical event, planned or otherwise, those days that you leave the hospital, it isn't where your care stops, right? It's really where recovery starts. So when we look at the data and we see the highest likelihood of those patients ending up either back in an emergency room or an inpatient setting, it's going to happen in the days following that hospital admission. So for us, that's why it's so critical in that transitional time period, when we think about the role that home health plays, that we get our clinicians engaged with those members as soon as possible. And that's true for all of the delivery models we've talked about so far, including primary care, including home health. So for us, that timely access and having a great relationship with those other delivery systems, where those patients are leaving from as they come on to some of our home services or need to be re-engaged, are really key for us. And then once we start that care, it's about assessing all the needs of the patient. So obviously, home health for us is anchored around those nurses and therapists that are coming in for a very specific skill set to help those patients with their specific needs in the home. But there's a lot more that we can learn about while we're in the home, and there's a lot more needs that we can provide for those patients while we're there. We think about one of those most important drivers and likelihood to cause a readmission afterwards is just the process of medications. So usually these seniors coming out, you know, they went into the hospital with probably a fairly lengthy list of medications that they took on a routine basis. The event likely added to that list or changed the list of medications that they need, whether it's the number, the dosage, the quantity, right? So that is all in play for us. So a key component for that timely start of care and effective start of care for any patient coming on to home health is to complete that med reconciliation process. So our 9,000 clinicians across our home health business today are doing that day in and day out for every new patient that's coming on service with CenterWell Home Health. But again, when we think about the opportunity that we have as an organization and all of us to kind of lean into the other care delivery aspects and other partners that we have to really provide holistic, integrated care for these patients and giving them the best level of service that we can to improve those outcomes. You know, at Humana, we realize we have a really unique opportunity to engage a pharmacist to help with that process. So our home health clinicians now in certain markets where we're leaning in and expanding this program is we're able to actually, at a start of care visit for a home health clinician, allow our nurses to virtually bring in a pharmacist that we have in our CenterWell organization to assist with that med reconciliation process. So just a really unique opportunity for us to bring in a licensed certified pharmacist to help that clinician, and everybody kind of wins, right? We get a more comprehensive review, which is going to help reduce that likelihood of having an adverse event, right? And that patient ending up back in an ER or inpatient setting. It's going to support that home health clinician and helping them do that med reconciliation extremely effectively. And it's going to give that patient the best outcome. So for us, we're really excited about what this is doing. We're going to be continuing to monitor those clinical outcomes long-term that we get from that partnership. But really excited about what we're seeing early on. You know, I think a couple of the leading indicators I would share is that about 92% of the time that we do a med rec with our pharmacist, we're identifying one or more drug therapies that there was a complication on, that the pharmacist needs to intervene and make an adjustment to that care plan. And then even understanding more from our clinicians, the home health clinicians, right, on the role and the help that pharmacist engagement is. You know, nearly half of our home health clinicians are saying, wow, you know, this has been a great benefit to us. We're learning a lot from having the support of the pharmacist, and we're definitely seeing interactions and opportunities being identified through that engagement that may not have been identified otherwise. So for us, it's really great, improves patient satisfaction as well. And again, I think this is just one of many of those kind of tools that we like to think of in our toolbox that we can offer to patients that are on service with CenterWell, with a goal to help them improve their outcomes, avoid that visit back to an ER and inpatient setting, and recover and live as comfortably as they can in the home setting, which is obviously going to be where they prefer to be.
Well, I have a couple of follow-ups. Incidentally, folks, if this is your first time attending one of our webinars or recordings, depending on how you're consuming this episode, and you should subscribe to the Bright Spots in Healthcare podcast. It's free. Anywhere you listen to podcasts, just go and subscribe. If you have an extra 60 seconds, write us up a rating and a comment wherever you listen, Spotify, Apple, wherever, or on YouTube. So I highly encourage you all to do that if you haven't already. If you want to get episodes like this one, just download it to your tablet and get alerted to them all the time. 12 o'clock on Thursday isn't always convenient for everyone. Two follow-ups. So one is, you mentioned getting the clinicians engaged early and then supporting the home health care provider, assessing the needs, medication reconciliation. I get all that, but talk to me about how you get the clinicians engaged early. Like, take me through like 60 seconds of what that looks and feels like. I'm getting discharged. I'm getting sent home. Like, what happens? How does that?
Yeah. So Eric, that really starts with us having, you know, great partnerships with the other providers that we work with in our communities, right? So understanding where these patients are coming from, and having a team of folks that are continuing to coordinate with those people and make sure that we're showing up in the best way and available for them as a home health option. And then the detailed work that happens within our home health agencies, right? So making sure that we've got all the care plan in place and supporting our clinicians so that we can be as efficient and effective as possible with the resources we have, and considering that clinician and therapist workforce. So that's kind of where it starts for us, is on the front end coming in and the good work that our branches do in all 350 of those locations day in and day out to understand the new patients that are coming in, prioritizing those schedules and getting out to people as soon as possible and putting in the extra effort to make sure that happens and no one's going without care that we know they need so critically after leaving that inpatient setting.
And one quick question from the audience, since I have you here, Chase. How is the CenterWell performing as far as how you're doing those home assessments right now? And are you using HRA service providers or are you employing them yourself?
Yeah, so for care in the home, I would say we have a mix of both, right? So we certainly leverage our own assets, and I mentioned primary care anywhere a little bit, where we've got our primary care providers going to the home and being able to do those assessments in the home. But we understand some patients may not have that available to them in their market. So we definitely work with a host of other network providers as well that allow us to get that interaction in the home for patients that may not be able to make it to a brick and mortar setting. So I think we've heard a couple of examples on this call that either health requirements, transportation issues, lack of caregiver support, are going to give us patients and members that have needs in the home. And we're going to always have a robust network of options to try to get to those folks so that they don't go unseen.
All right, I'm just unusually behind schedule here. I apologize to everyone. I want to circle in back to the business model here of how you could fund this stuff. So I'm going to bring Randy in, and then Dominique, I'm going to bring you in to talk a little bit about doulas, because that's a super important topic. Incidentally, folks, our next live show is November 2nd. It's called Beyond Medication Adherence, timely, unleashing the power of member engagement to elevate outcomes. We already have CareFirst on the show. We have a couple of the plans that are going to be joining them. It's going to be a really good discussion. If you want us to register you Thursday, November 2nd for the live recording, 12 o'clock, we're going to put up a poll. We'll register you so you don't have to do it again if you want to join us on November 2nd. So, Randy, aides and caregivers are typically not employed or reimbursable by the plan or ACO. Dominique mentioned earlier, financial sustainability. The aide more often does not even know the insurance company organization supporting their member or their family member, despite being in their home for over 40 hours a week sometimes. And the health plan, even though that individual is taking care of their member for over 40 hours a week, they probably have no idea who they are. They're invisible to the health plan. So how can health plans listening and ACOs listening get more leverage from their aides and their caregivers in general? And how can they truly create a partnership with the home health aides to create financial savings for the business, get better clinical outcomes, and maybe even create more sustainability for that individual home aides kind of career as well?
Yeah, I mean, this is one of those terrible artifacts of the American delivery system. You've got a bifurcated funding stream where medical care does not pay for aid care and caregiver support in a meaningful way. And typically Medicaid or privately paid for funds that are paying for the aid level care, if it's even paid for at all, are segregated out from the rest of the system. Even in integrated plans, this is a problem. So, when you talk to a medical plan, typically they know, and I think about Chase talking about some of the Humana stuff that's there, and you guys are real leaders in home-based care. How you fund actually engaging with aides is a challenge. We have some good use cases, and we've got a really unique approach to this. What we found works for us is that we're actually not a home care provider at all. We are a virtual care internal medicine group, and our services wrap around the Medicaid funded or privately paid for uncompensated care. And what this does is it allows for a bridge to be created, and a medical payer can now connect with the people that are in the home around specific covered benefit type objectives. So this includes engaging aides and caregivers in things like outcomes improvement, quality gap closure, helping to keep people safe and at home under accepted and understood framework, HEDIS, STARS, what have you. This is really effective because aides and caregivers and agencies are typically, they want to do the right thing. They want to differentiate. They want to help, keep people safe at home. The other part of it is it's to their financial advantage to do that. So if you are an agency operator, you don't want people going to the hospital. If you're an aide, you don't want your patient going to the hospital. If you're a caregiver, you don't want your patient going to the hospital. So you've got a group of people that are naturally aligned in this effort. So the way that it works is that plans contract with us as a provider. We organize a program that's designed to engage with the people that they serve. And then we work with the agencies and the aides themselves to work on specific quality improvement efforts around these patients. And because these patients tend to utilize resources forever, right? These are long-term supports and services individuals, we tend to stay engaged with them for a very long time. We then use our access point with those aides, it's a new access point, to help connect the patients back to their primary care, who oftentimes don't have good access to the aides, typically very rarely do, and have difficulty serving these patients as a result. So it ends up being something that reduces the burden on primary care at the same point in time that it increases the leverage and support of the people that are in the home. So there's specific things that we work on with our agencies. And again, these are not things that I think most people think of as personal care agencies, consumer directed. These are different, but achievable. We'll work on falls prevention programs with them. We'll work on HEDIS metrics with them. We'll do bi-directional data sharing where insights and observations coming from the home create action, which create training back for them. I think about, Dr. Beane's comments about, how 1199 is training aides as CHWs. Well, aides are really, really close to CHWs. They lack the training and support to be able to do it. But from a licensure perspective, they actually have a lot of what it takes to. Caregivers are uncompensated, but have a very similar role there. So, we end up working with them as a provider group in the same way that a provider group would work with a CHW in general. People have asked me why this hasn't happened before. Where did this, why is this existing today and it didn't exist a couple years ago? And there's a couple of things that really changed in the environment over the past few years. Obviously, the emergence of telehealth during the pandemic made a huge difference. Plans being more accepting of that, patients being more accepting of that, and then new reimbursement models that are available under covered benefit from CMS has also made it more accessible. So you end up having a whole lot more payment innovation than maybe people would think as a result of that. So, I believe the time is now and the world exists where we can align on outcomes and we can create reduced burden for providers and better reimbursement for the people that are there and better support. If I sound passionate about it, it's because I am. I think there's a huge opportunity. 4 million paid aides, 57, 60 million caregivers that are out there in an overtaxed system, and they are underutilized and deeply needed.
Love it.
May I just build on what Randy's saying, Eric?
Yeah, go ahead.
Yeah, I just don't want to forget this point, and I'll be very brief, but the fact that CMS is actually in favor of these kinds of innovations, and New York State is about to dip its toe into that water as well. And CMS only does these things because they believe it's a return on investment to the Medicare program. So, I do think that from our perspective, this is not something that turns in a return on investment in a year or 3 months, or, it's trying to change the trajectory of health for people who, if you don't have an intervention, will likely be very expensive in the future, changing how they feel in terms of caps and the health plan, and certainly how they feel connected to their provider. We've actually shown that you begin to change the trend in patient satisfaction with care coordination by their provider by assisting in this way.
I love it. So folks, just so you know, reminder, right now, you got an email from me asking for feedback. I am maybe setting an all-time record for the show, 10 plus years of being behind schedule. So you could criticize me there. And anything else you want to suggest. One of the topics tied to everything we've been talking about today that's near and dear to my heart is this concept, or this notion, this fact that in certain markets around this country of ours, women on Medicaid have as much of a 15% chance of their newborns ending up in the NICU, which I think is a staggering and an embarrassment of our healthcare system. And so I am going to be covering this topic in about a month on this show, and I'm certainly excited to produce that episode, so stay tuned. But Dominique, I want to bring you back in. Can you share what Health Leads is doing with care at the home to dramatically impact access and quality of care in this area of both prenatal and postpartum health, and maybe share some guidance on what health plans and health systems could do to maybe mimic a little bit of what you're learning and doing?
Yeah. So Susan actually alluded to some changes that the state of New York is instituting in 2024 to the Medicaid program to expand who can provide services and get reimbursed for it. And doulas is part of that expanded process. We've been very fortunate, Health Leads, to help lead the doula coalition in New York to help to get that across the finish line and signed and all the rest of that. And so really excited about the impact of that work, both for the impact on children, but also mothers, especially in underserved communities and on Medicaid. So As we look at kind of how to expand that, because we know that negative infant outcomes as well as more maternal mortality and other things are a real issue in a country that it shouldn't be a real issue, and especially across other parts of the United States. One focus area for us is the South. I'm a Southerner by origin, and so it's near and dear to my heart. We're looking at not just kind of the work that we can do with community-based organizations, and that's for sure, but what I think has been incredibly useful and will leapfrog a lot of these efforts is collaboration with health plans and health systems, as well as payer organizations that serve these patient populations. You mentioned kind of outcomes related to NICU, but even basic outcomes like reduction in C-section rates, improvement in breastfeeding rates, and also a reduction in postpartum depression or the earlier identification of postpartum depression are just sort of 3 facts that you can put dollar signs tied to it that doulas help to effectively reduce and manage when engaged in folks' care. And so there's a growing understanding, and there's about now 10 states with the state of New York who have kind of approved processes for doulas to be able to be seen as a licensed provider who's providing assistance and care, again, similar to, as Randy has mentioned, as part of a wraparound. This is not meant to be to replace the obstetrics care that they get in the office, but actually it improves the obstetrics care, because in a lot of populations, and the folks are actually more likely to show up to their visits. They're more likely to engage with their prenatal, antenatal, and postnatal care, which means that both for mommy and baby and families in general, we have better outcomes.
Well said.
Thank you.
I don't know where to go here with about risk of going long. I think what I'd like to do, Randy, is circle back to you, knowing that you have like 2.5 minutes here. I want to get, because I'm just a big believer that any of these altruistic programs need to have a capitalistic engine, or they're not going to be sustainable. So can you get back to sort of how does the business partnership work to be able to fund programs like this, and maybe give us a little bit of just overall funding caregiver support so that it checks all the boxes, the health plan wins, the caregiver wins, etc.
Yep. So taking you through the chain, it's pretty simple. We are a medical group. We admit these. So patients get referred to us from the delivery system, typically from home care agencies, but also from plans and primary care providers. They are patients that have long-term home-based care needs. We come in with a model where we admit them, much like any other provider, and then we bill claims for them, much like any other provider. What's different between us and other providers is that we make the aides and the caregivers literally part of our team. And what that means is, as opposed to hiring staff who are going to go in and out of people's homes that already have them, or hiring office staff, we actually pay the aides and the caregivers and the agencies in our model out of what we get paid to help us with administering our model. So it's not just financial alignment, it's actually financial connection. It's all done at fair market value. It's all done in a very compliant way to make sure that we don't have any type of adverse incentives or anything like that happening. But as a result, we're leveraging people that are already in the field, in the home, doing things to assist us with a model that is really important for the connection points. From the standpoint of the payers, if you are a medical payer, you're winning under this model because you're getting really actually very low cost services on balance. These are Part B primary care type claims with improved documentation, improved quality, and improved outcomes. We do that on a financially aligned or quality aligned basis. We'll take risk around populations. If you're an agency, you're winning because you're holding on to your patients longer. You're seeing lower churn. You're seeing higher satisfaction. And if you're an LTSS payer, you're winning because you're actually avoiding health events. And avoiding health events is how you avoid the growth of trend. Hours rise when people go to the hospital and have a health event, and they come back and they require more services. People move into long-term care facilities, which are very, very expensive. And what we're doing is helping people stay safer at home longer, which actually saves the LTSS plan money. So it is a directly linked end-to-end, truly financially and value aligned program that oddly enough sits on a fee-for-service chassis.
Great way to close. I know we're at the top of the hour. So I want to thank all of you at our, thank you for the time and effort you took to prepare for today. I know you're all really busy. And thank you to all of you listening and watching, for allowing all of us to fit on your busy calendar. We know you're all busy, blocking off an hour of your day, whether you're on the weekend listening to this or live here Thursday at 12 o'clock East Coast time, now 1. We know that it's a commitment and a sacrifice. So we thank you for trusting us with your time. We hope you use the bright spots and ideas shared today to inspire your thinking and enhance your company's current approach to home health care, caregiving, and improving healthcare for all of us. Remember, we produce this show for you. This is your Bright Spots in Healthcare podcast.